right, good morning. Happy Monday. Blended week. This is the lecture for adult conditions, spinal cord injury. So Dr. Wingard here. Enjoy your week. I know you still have to come in for culture, but let's go through spinal cord injury. I have a lengthy PowerPoint presentation that is good for you. I've left it pretty lengthy, but I'm not going to go through it in too much detail. A lot of this stuff is covered in your reading, so I kind of want to hit the important stuff through here for you. So watch this video. I've got some good videos in here as well along the way. So make sure you take a moment and watch each of those videos. Go to those websites. When we get to the Asia website, make sure you go to that website, read through all that. That's good stuff for you. That's good stuff for you. So, all right. This is, one of those conditions that we cover that I'd rather cover in class. It's a fun one to go through. It's a big part of our practice. It's a really big, you will see, I have seen lots of folks, men and women, children with spinal cord injuries over the years. Some are heartbreaking, some are inspiring, and I've just loved working with people, and I have some fun stories. Don't let me forget one day to tell you my poo story, my great poo story, which involves a man with a spinal cord injury at Kaiser Rehab. It was fun. All right, let's get to work. So, spinal cord injury is that spinal cord, anything that injures the spinal cord, and we're going to see a disruption in the flow of information, motor information, sensory information, which is going to have a direct impact on function. It can be, manifest in any number of ways, we're going to find out. It's kind of like everything else we've talked about so far. Just because someone is diagnosed with a spinal cord injury, it gives you an idea of kind of what to look for, but everybody has a different injury. So where the injury occurs in the spinal cord will determine, and how bad that injury is, will determine how that impacts that person's ability to do things and to function in their world. So don't be prejudiced about diagnosis. I'm going to keep talking to you about that. When you see a diagnosis, don't just lump that person into a category. Everybody is different, and every condition is different in some way. So be mindful of that. You have the stats in your book. I hope these line up. More males have spinal cord injuries than females. Again, I don't want to speculate. I'm not saying men are stupid. I'm just saying this is a fact. Okay. So we see leading causes of spinal cord injury. Motor vehicle accidents are a big one. Sports injuries, falls, acts of violence, gunshots, gunshot wounds, or whatever. Lots of different ways people can be injured and have a spinal cord injury. And I'm interested in seeing in your exploratory activity I've included, I want you to research the stats of your home state and the leading causes of spinal cord injury. So most of you are from Oklahoma, but some of you are from other states. I'd like to see that, and that'll be part of your thread of discussion as well. Okay. Come on, work with me, smartboard. So go back, we don't have to go back through this in our class, but review your vertebrae, right? Review your spinal column protects the spinal cord. Review your anatomy. Notice the different sections. And in your spinal cord, we're not going to go through this, we went through this in neuro, but review your spinal cord sections, your spinal nerves over here. Review your pathways, your tracts, sensory tracts, motor tracts, etc., etc. So, review your neuron, review your spinal cord cross-section, review your components of your spinal cord. what's sensory afferent, what's motor efferent, gray matter, cell body, synapses, all that stuff. That's now going to come in very handy as we talk about spinal cord injuries. We learned that very well just last semester. Went too far. Went way too far. Okay, good. Yeah, I should be able just to tap this thing and it work, right? There's something wrong with my fingers, maybe. Maybe all that guitar playing, I have calluses on my fingers, don't even have any fingerprints hardly. So anyway, so there's incomplete and complete spinal cord injuries. Sometimes somebody will have just a complete spinal cord injury and there will be a complete disconnection, if you will, or interruption of the flow of information. But there's also incomplete spinal cord injuries. Part of the spinal cord will be injured. And there are different syndromes that arise that people will have. And that's where your assessment comes in, your evaluation, to see what their issues are. And I'm so close to being competent. I'm so close. So anterior cord syndrome, let's talk about anterior cord syndrome. You see the anterior aspect of the spinal cord is damaged, okay? Now you're gonna have a loss of movement, pain and temperature, still able to feel position, vibration and space. I want you to know your anterior cord syndrome. Come on, baby. Brown-Séquard syndrome, only one side of the spinal cord is damaged. You'll see this frequently with gunshot wounds. You'll have ipsilateral loss of function below the injury. So generally speaking, with a spinal cord injury, especially if it's complete, you're going to see a complete loss of function, sensory and motor function, below or inferior to that level of injury, okay? But in incomplete spinal cord injuries, you're going to have different manifestations. Brown-Séquard, you've got one side of your spinal cord damaged, and you're going to see ipsilateral loss of motor function below the injury, ipsilateral reduction of deep touch, proprioception. Notice contralateral loss of pain, temperature, and touch, right? Okay. So it's Brown-Séquard syndrome. So you notice this is where the damage occurred on one side of the spinal cord. Central cervical cord syndrome. So we'll see that more in the central part of the spinal cord. You'll see damage there. Upper extremity tends to be more impaired than the lower extremity. Maybe this could be caused, for example, by neck hyperextension and narrowing of spinal canal. Those are the most common causes. And as people get older, this is more common with folks like me who are getting older. One more thing to look forward to as I age, okay? And you'll see with anterior central cervical cord syndrome, if the anterior horn cells in the cervical spinal cord are damaged, you'll see some flaccidity in the upper extremities. Central cervical cord syndrome. So this is where the damage tends to be. Okay, oh shoot. Okay, that was the next one. Cauda equina, remember now, the cauda equina is as you're going inferiorly to the spinal cord in the cauda equina, cauda of course meaning tail, equina meaning horse, so it looks kind of like a horse's tail as you get down to the southern part of the spinal cord. So we do see people who have a cauda equina spinal cord injury, and we'll see damage to the spinal nerves below the end of the spinal cord, so lower extremities are more impacted, affected, absence of reflex arc, loss of motor function, sensation, and we'll see flaccidity. And a lot of times with people with spinal cord injuries anyway, we'll see a lot of lower extremity low tone, flaccid tone, but not always. Sometimes we see increased tone in some cases. So that's cauda equina injuries. Reflex arcs are affected oftentimes with spinal cord injuries. Remember, with reflex arc, we talked about this in neuro. We don't have to go into this very much, but you know, so in a spinal cord injury, of course, the flow of information up and down the spinal cord, motor and sensory information, what have you, is interrupted at that injury, that level of injury. But also, reflex arcs are interrupted as well. So if you have spinal cord injury, you might see some reflexes. And the reflexes, of course, go to the spinal cord and back. They don't go up or down the spinal cord. They stay at that level. But with a spinal cord injury, you can see some reflexes interfered with or interrupted or just absent at that level of injury and below, okay? Now remember the difference between upper motor neurons and lower motor neurons, right? So upper motor neuron injuries tend to be brain and spinal cord, and lower to where the tract synapses at the spinal cord level. Remember that. The lower motor neurons are where that synapse occurs, and then out to the peripheral nerves. So in the spinal cord injuries, if there is an upper motor neuron injury, this is what's going to be happening, right? The reflex arcs are going to be intact below the level of injury. You're going to see loss of voluntary motor function, spastic paralysis. So they're paralyzed from that level down. And you're going to see spastic, so you have this increased tone. You're going to have hyperactive reflexes. But with a lower motor neuron injury, if there are lower motor neuron injuries, you're going to see a loss of voluntary function below the level of injury. And you're also going to see flaccid paralysis. You're going to see muscle atrophy in the absence of reflexes. So the big difference is with the upper motor neuron injuries, you're going to see the spastic paralysis, the increase in tone. And with the lower motor neurons and peripheral nerve injuries as well, which we haven't got there yet, we will, you're going to see the flaccid paralysis, okay? The muscle atrophy, just from disuse and lack of tone and the absence of reflexes. Okay, so here's a good visual about upper motor neurons. Upper motor neurons can be the brain. With a stroke, brain injury, you can see those upper motor neuron damage. The spinal cord injury, you can see these tracts involved as they're carrying information. That would be an upper motor neuron. But the lower motor neuron lesions would be at the nerve root, where the synapse is going out, and then peripherally. So when we talk about spinal cord injury, you know, we use language like quadriplegia, paraplegia, and all that. So as you probably already know, quadriplegia and tetraplegia, they're the same thing. You'll see both of those. In Oklahoma, in America, and in the Mid-South, the Midwest, we just use the word paraplegia for the most part. You might see tetraplegia, just be aware of that. But usually we use paraplegia, we use quadriplegia, and you'll hear language like, so in school you won't hear us talk like this probably, but in the clinic you will. You'll hear language used like, that person's a quad, or that person's a para, or that person's a whatever, a hemi. You'll hear that language, and we don't use that in school because we like person first language, right? But the spinal cord injury community, people who have spinal cord injuries and just people who are in that community use that language. So it's not offensive. It might seem offensive in an academic setting, but out there in the real world, you hear that language. You don't have to use it if you don't want to, but you'll hear it anyway. You know, you'll have a patient and she'll say, yeah, I'm a para, and I participate in the Paralympics, or I do this or that or whatever. And there's lingo and language that goes, and that's part of that community. So just be aware of that. There's nothing wrong with that. In academia, we don't like to do that. We kind of poo-poo that, you know. We want to be person first. We don't want to offend anyone, which is fine. I don't want to offend anyone either. So we'll say a person with quadriplegia, a person with paraplegia. And quadriplegia is with paralysis of all four extremities, tetraplegia as well. Whereas paraplegia is the paralysis of lower extremities. Monoplegia, would be just one. And then you have hemiplegia, of course, which we already know about. So anyway, be familiar with the language. Go to the ASIA scale website and be walking through the ASIA scale and read through that information. That's good stuff to know. You might see that out in practice, and depending on where you work, you might not. I mean, if you're just working at St. Francis acute care, you might not see any of that. But if you're working at a place where they're really into spinal cord injuries, they may even specialize in that, you might see the ASIA scale. So that's really for your familiarization. Secondary complications that you might not have considered is that people will suffer maybe spinal shock immediately after injury. Sometimes they will have spinal shock, lasts 1 week to 3 months, and you'll see flaccid paralysis below the injury, flaccid bladder requiring catheterization, followed by increased flexor spasticity, followed by increased extensor spasticity. So it's just your body's way of dealing with that and how the spinal cord has negatively impacted the autonomic nervous system, etc. So you might see tone fluctuations. Dr. Mike has a really cool video. I actually have it in here twice. I put it in here because he talks about some of these things in his video, and so it's good. So anyway, so not only do they have spinal cord injury, but they might have these secondary complications: spinal shock. Respiratory conditions are a big deal with spinal cord injuries, especially the upper level spinal cord injuries, because they affect the respiratory system, respiration. In fact, people who have a C4 or above spinal cord injury will need to have help breathing, so they'll need a respirator. So one cool person to study is Christopher Reeve. He's important to my generation because when I was a kid, he of course played Superman. His Superman movies were big, and so he was Superman to us. Great looking, athletic, fantastic. He's got just a fascinating, tragic story. I mean, he was very active, and he was big on horseback riding and competing. And what is that horseback riding competition where you jump over things? Blanking on that word. But I believe what happened with him was he was in one of those competitions, his horseback riding, and his horse stopped short of an obstacle, and he went flying over the horse, and he landed on his head and broke his neck, and he was, I believe, a C1, C2 spinal cord injury. And for years he was in a wheelchair, and he had to have help breathing, and I've seen him on TV. He was actually in a movie. He was in movies after that in a wheelchair. He even did the old Alfred Hitchcock movie, which was a guy in a wheelchair. I forget what it was called, maybe The Window or something like that. But anyway, great actor. He lived for many years after his spinal cord injury, and he had to have a respirator on his wheelchair that he went around with. And he had a sip and puff system for his power chair, and just a great guy, fascinating. It'd be a cool case study for you to just go Google Christopher Reeve and see what happened to him, and watch a video by him, listening to him. He's great. He was great. He passed away though. Okay, so anyway, that's a secondary complication. In fact, most common, people who die following a spinal cord injury, the most common cause of death is respiratory complications, pneumonia or something from some respiratory complication. Deep vein thromboses, a very common secondary complication. They're just not mobile, they have decreased tone, they have decreased mobility, and and here's something to be really mindful of when we have spinal cord injuries. People who have paralysis, those paralyzed extremities, they just bang them when they're moving and they're transferring, especially spinal cord injury, especially people who are have paraplegia, they got good arm strength. They can get around pretty well using their arms, and it's easy to bang their legs on stuff. And so we'll see DVTs develop, and wounds, sores on their lower extremities too. So we really teach them, especially initially, to be very cautious, very mindful of taking good care of their legs and feet when they move, and they transfer. Protect that, check that regularly, check for sores, check for whatever, anything out of the ordinary, and we want to prevent the unseen things we can't see, like DVTs. We've talked about autonomic dysreflexia at length in neuro. Just review that, refresh your memory on that. It's, your autonomic nervous system is just not working correctly. It's exaggerating its response to stimuli, right? So we remember the signs: sudden headache, flushing, goosebumps, profuse sweating, diaphoresis, profuse sweating all of a sudden, right? Increased heart rate, very fast heart rate, then bradycardia, slow heart rate, one extreme to the other. So anyway, caused a lot of times by maybe the catheter has been messed up, has been pulled, or we'll see overfull bladder or bowel. Decubitus ulcers can cause this as well. So anyway, so with postural or orthostatic hypotension, hypo meaning a low blood pressure, right, below, we're going to see a sudden drop in blood pressure secondary to blood pooling in the lower extremities, right? So we go from lying down, maybe we have them sit up, and this happens. Maybe we go, sometimes people will go to a standing position. We don't have this with spinal cord injuries, but in their hypotension will drop, their blood pressure will drop as a result. So, but usually with our spinal cord injuries, when we're sitting up in bed, they've been sleeping all night or whatever, sitting them up in bed, we've got to watch their blood pressure, give them a second to adjust before we move too fast. Okay, just be careful with it. We have lots of issues with bowel and bladder with our spinal cord injuries. They just don't have the control they used to have. And so we're going to have, a lot of times with bladder, they're going to have, sometimes they'll have a spastic bladder, or sometimes they can have a flastic bladder. They're at increased risk for developing urinary tract infections. And you will also see issues with constipation, sometimes diarrhea, impaction. It just, things aren't moving like they ought to in their bowels, in their gut. So the peristalsis, the motor component of moving bowel, is just not working as well, so things can get impacted or slowed down or whatever. So there's a good YouTube video about catheterizations, bladder from a person with spinal cord injury. And of course, pressure considerations. So if you can't feel part of your body, your lower extremities, or even into your upper extremities, you're going to have pressure concerns, pressure considerations. Prolonged lying or sitting on bony prominences especially, but anywhere, they're at increased risk for developing pressure ulcers. These are referred to as pressure ulcers, pressure sores, bed sores, decubitus ulcers, and you'll see different language out there, people referring to them in different ways. Basically, you have what I like to explain. If you take your finger, do this right now, take your finger and push on your skin and then let go, you'll see it's white for a second, right? It blanches. So what you're doing is the pressure causes the blood flow to be blocked to that tissue. So if you hold that long enough and you cut off the blood supply to that tissue, those skin cells in this case, or to other tissue, what happens? If you cut that blood pressure off, you cut that blood flow off long enough, so blood is occluded, oxygen, nutrients, everything can't get to the tissue, to those cells, and those cells die. That's what a pressure ulcer or a decubitus ulcer is. There's been a blockage of blood flow to tissue, and tissue has died or is dying, right? And so we need blood flow. So to prevent that from happening, what do you have to do? You have to alleviate pressure, right? Me pulling my finger off of my skin alleviates pressure and allows blood to flow into my tissue. So if I'm sitting for prolonged periods of time on my ischial, and I've got my hands in my butt, my hands in my ischial tuberosities and my coccyx, I don't have to put my hands there, but imagine. What happens? Those are bony prominences, and they're really created to bear weight. So we bear weight into our ischial tuberosities. Our coccyx, these are close to the surface of the skin. And so if you sit there too long and bear weight, the pressure cuts off blood supply, and the tissue in that area dies. And so that's very common places we see in sacral, coccygeal, ischial tuberosities. We see these bed sores there. But anywhere where you're lying, sitting for prolonged periods, you can develop these. So, and you and I, we have intact nervous systems, we feel this, and so we make adjustments. We don't even think about it. We make postural adjustments based on the incoming sensory information. Doesn't even have to be conscious. It's just stuff that we do. When we're sitting, watching a movie, we're sitting in class, we just kind of turn, move around, cross our legs. These are postural adjustments that we make to alleviate pressure. And when we're in bed, we don't lie in bed in the same position all night. What do? Well, I toss and turn, but anyway, what do? You roll, you move, you make postural adjustments throughout the night, unconsciously, to alleviate pressure. But when you have a spinal cord injury, or a stroke, or whatever, any number of other things, and you're not able to feel, and you're not able to make these postural adjustments unconsciously, just naturally, then you have to be very purposeful and intentional about making these postural adjustments, okay? So, pressure considerations. This is another good video. Take a moment, watch this video, watch it multiple times, it's very good. So, that's why you'll see, and we'll talk about that more in another course. I think Dr. Estes goes into great detail on this in another course, about positioning. There are certain cushions that are really, really good for spinal cord injuries, gel cushions, for example. There are air cushions people like because it helps with pressure. It helps prevent these decubitus ulcers. All right. So sometimes people will have, if there's a bony spinal vertebral problem, they may have to have that part of that, the lamina of the vertebra removed, for example, to remove pressure on the spinal cord. They might have two vertebrae fused together. We also use some, and I have pictures of this later on in the PowerPoint. You might have to have a brace, right? A thoracolumbar sacral orthosis, TLSO. How you like that? It's a mouthful, ain't it? Might have that. Some people, we call it a clamshell out there as well. I have a picture. A halo for cervical injuries. It's just fixating, keeping things immobilized. We use steroids for decreasing inflammation. Therapeutic, you can look these up. Look each of these up. Take a minute, look each of these up on your own. Therapeutic hypothermia. So we're going to use cold here for therapy. And we can use electrical stimulation as well to help manage some of these symptoms. Know your spinal cord levels. I hope you can see that okay. It's in your PowerPoint. Know your spinal cord levels. Your book has some really great graphics. Spinal cord levels, muscles involved, and also how those spinal cord level injuries at those levels impact function. Occupational engagement, however you want to say it. So that's really good. Notice the lower you get, the more upper extremity, the lower the level of injury, the more upper extremities you have, and the more lower extremities you have. Okay. So here's a great example of the halo. Notice you've got stability, stabilizes this. This person's not, it's just keeping it from, maybe there's inflammation, maybe it's healing, and it keeps it from being in, it keeps it immobilized. And then you have the clamshell prosthesis as well. All right, a tenodesis grasp. This is an important thing. So we like to, so if our patients don't have finger flexion and extension, right? Because, especially finger flexion, because of a spinal cord injury, you notice that if you flex your wrists and try to flex your fingers, you have less power, right? Active insufficiency here. You have less power. And if you notice that you really have the greatest strength and the greatest power of grip when your wrist is extended a little bit. It's because of active insufficiency, and when you stretch your tendons a little bit, your flexor tendons are being stretched across these joints, and it increases their tension. And there's a point in which, right here, they just have the most power. We can use this to our advantage. When we have people who have spinal cord injuries, they might have some, they have some wrist movements, and we teach them to get some wrist extension, and then they can use their fingers better. So if they're just like this, they really can't use their fingers a whole lot, but if we get some wrist extension, 20, 30 degrees, 40 degrees, 20, 30 degrees, we're really gonna have some improved finger flexion. I've done this over the years with so many different people. And when I point this out to them, it blows their mind. Wow, I can move my fingers better when my wrist is extended. So we can see, we can make a brace for them, an orthosis, a splint, a tenodesis splint, where it keeps their wrist a little bit extended, and then they can, even if they can't do it themselves, if we can get them into some wrist extension, they can have more finger flexion and actually have some function with their fingers. So that's a cool, it's called tenodesis grasp, and it's the utilization of wrist extension to promote, I don't know why it says passive finger flexion, but to promote improved active finger flexion. All right, more on the spinal cord level, injuries, and how it impacts function. And if we were in class, we would go over that, and it's part of your exploratory activity, and it's part of your thread of discussion. So I'm trying to guide your thinking into going from thinking more generally to really getting more specific in your thinking. Now think specifically, how would a C7 spinal cord injury impact somebody's ability to feed themselves? How would a T12 impact somebody's ability to get dressed, upper body dressing, lower body dressing, whatever? Pushing up with arms for pressure relief, right? How would people with a spinal cord injury be able to, depending on their level, alleviate pressure, make postural adjustments, supine to sit, holding a cell phone, etc. Okay, so I've got some videos in here that if we were in class, we'd take time. So take a minute, watch. That's the same Dr. Mike video that I had earlier. I want you to watch that video. He's got other cool videos as well. Don't mind the muscles, just ignore his muscles, okay? Now, these other videos are really cool. Here's a person with a C5 spinal cord injury. He has a video about how he transfers into the bed. It's somebody we watched earlier with the catheterization. There's a person with a T12 spinal cord injury transferring. He's transferring from his wheelchair to a couch. He's more of a has more paraplegia with T12 injury. Obviously, he's going to be more lower extremities involved. He's got good upper extremity use. T2, level T2, car transfer, and the same guy from the bed transfer, he doesn't have a lot of finger flexion. He's a C5 injury, and he does a cool video on how he puts his hair gel on. I just thought, I liked it. I thought it was interesting, and I thought you would, this kind of stuff's important to us these days. I need to get hair gel in my hair because my hair looks like crap without it. So I know my patients want hair gel in their hair. They don't want their hair to look like crap either. So it's a cool video. I want you to watch that video. And that's the end of the slideshow. How do you like that? Okay, so you're already working on your exploratory activity. You're already thinking about your thread of discussion, your initial posts. I felt like the initial post, the thread of discussions went great last week. Really, it was exactly what I was hoping for. I thought you answered the questions well. You were fairly thorough and thoughtful. Be more detailed. I'm not talking about being long-winded. I'm not talking about being blah, vomiting all over it. I'm talking about you can still be concise, but I'm trying to get you from going to be general, from being so general to being more targeted, more specific and detailed. So for example, if somebody has a T2 level spinal cord injury, it will negatively impact this person's ability to get dressed and go to the bathroom and all that. Okay, well that's a general statement. Now, how would it impact? Get specific, give an example of how, and think about the specific ways in which the spinal cord injury would impact this person's ability to get dressed. From a sensation standpoint, from a motor standpoint, how that would impact functional performance, occupational engagement. Get a little more detailed. So I just want you to go start thinking. I want you to think big picture, but I also want you to zero in and get detailed when it's appropriate. That's how OTs think. That's how I think as an OT, right? Big picture, now we're gonna zero in, boom, 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 and think more specifically of how this would play itself out in real life. Notice also in the instructions, I want, now that you've got one of these under your belt, one of these threaded discussions, I want 2 good references in your initial post. And I want in-text citations in your initial post. The whole point of the in-text citation is you're telling the reader, this, what I just put here, I didn't come up with this. This is not from me. This is from, I'm crediting a source, right? I'm crediting, Dr. Bates wrote this, I'm crediting her with this, what I just wrote. So your reader knows that didn't come from you, that comes from a source, and you're putting that in the text, the body. And now I as the reader, or you as the reader, can go to the references and see that reference in more detail enough to where if you want to go look that reference up, you can. Sometimes I like to go look those references up. I want more information. This is a good tip for research, by the way. As you go through your research course, one of the greatest ways to get resources, to find good sources, is in the reference list of your sources. So you might have a really good article on something, and you look through that reference list and you find more good source. I have found myself going from one thing to another just by finding good references and going checking those references out. And they have references, and they have references. So there's no excuse for not being able to find sources, good sources. Your literature search is going to yield some, but also check out those references on those good sources that you have. That can lead you to some really good sources as well. Okay, so anyway, enough said about that. Have a great week. We'll see you next week in class.